So this is a live in-box case which we had done earlier and transmitted to one of the conferences, Dr. A. Srinivas conference.
been the mission of Apollo hospitals. The one in Delhi is the largest called SA and the fourth largest in the world. Apollo is the largest hospital network in Asia. That being a world-class healthcare provider is not just about medical expertise. It's about touching lives.
The coronary angiogram showing a severe disease in the diagonal bifurcation. Next slide. And a severe disease in the LAD diagonal bifurcation. Next. The patient came to us with severe TIA, recurrent TIAs in the night, and at that time we took the patient to the cath lab. Next please. So this is the right coronary angiogram which is normal. Next. Now this is the angiogram, the right internal carotid artery, if you see, has a 99% stenosis with a thrombus, there, and this the patient was having recurrent TIA, and we did a duplex which showed a thrombus there, and we were very scared that if we pass a wire there or a distal protection device, we may embolize it and cause a impending stroke to establish stroke. So what we did an angiogram on the other side. Next please. This is the same side showing a thrombotic 99% occlusion. Next please. We did a vertebral shot here which showed the vertebrals were normal on both sides. Next please. And there was a 90% stenosis. Next on the left internal iliac artery, internal carotid artery also. Next. Okay, so we had a choice. We could not use a distal protection. We thought of using a proximal protection. We were a little skeptical because we had bilateral internal carotid artery stenosis which were tight. But since the vertebrals were good and we had no other choice because there was a thrombus there, we thought that we will take a chance, and the patient tolerated the procedure well. So this is the angioplasty on the right side. Next please. We do our procedures under roadmap, and we passed in a guide wire into the external carotid artery. Hooking the innominate and the right internal carotid, right common carotid was not difficult. And after that, we passed in the MoMA device. This is the MoMA device. Next, please. The proximal balloon is in the common carotid artery. The distal balloon is in the external carotid artery. Next, please. Then we dilate the balloon, and after that, once we do this, we can sort of reverse the flow. And as you see, once we give the contrast to the MoMA device, the contrast stays there for a long time, and in fact there is a risk of embolization is very low. We can actually see there is a negative contrast coming from above. Next. After that, we pass in a whisper wire. We had some difficulty passing the whisper wire across the lesion, but we could, with some negotiation, we could actually pass through the whisper wire through this. And after that, we took a 1.5 millimeter balloon and a 2 millimeter balloon to actually dilate this lesion. Next. And then we got our stent up, and this is a Cristello ideal stent which we normally use for these sort of lesions. We want a closed cell design to be actually covering the lesion which is quite tight and has a lot of muck so that the embolization is low. Next. And after that we deployed the stent, and after deployment we pulled out the stent over the wire. It comes out very, very smoothly. The patient tolerated the procedure quite well. This is about a minute with occlusion. Next, please. And then we aspirate. After this, we aspirate and then post-dilate. Normally, we do the aspiration in the end. I sort of do it twice. Now, this is a post-dilatation with a 3 millimeter balloon. Next, please. Next. And then we go with a 5 millimeter balloon. Normally, I dilate my carotids just to a 5 millimeter or a 6 millimeter and then leave it because these are self-expanding stents. Then we repeat the aspiration again 3 times. We could recover some bit of clot and an atheroma. Then we deflate the external carotid balloon. Next, please. And now the external carotid balloon is deflated. We see a good result in the internal carotid stent. Then we deflate the common carotid balloon of the MoMA device. Next, please. And then after we complete the procedure, we just pull out the MoMA device. It comes out very, very smoothly. It has, in my experience, it has never ever sort of been stuck between the stent and the carotid vessel wall. Next. So this is how we pull it out. It's just a very simple pull and the whole device comes out. Next, please. This is the final result. The TIA was resolved on the table. Next. And this is the cerebral angiogram, which shows there is no distal embolization. Next. Then we proceed to the next site. It was a difficult access, so we used a Simmons catheter to access the left internal carotid, common carotid artery. And next, we took an, next please. We took an Aquatrack wire, and then after we got our guiding catheter up, we passed the Aquatrack wire into the external carotid artery, again like the previous case. We can see a tight stenosis in the left internal carotid artery as well. Next. And after that, under roadmap, we repeat the same procedure. We pass in a guide wire into the external carotid artery. This is a 035 Aquatrack wire from Cordis. Next. And we then place the MoMA device. This is the same MoMA device. We have not used the second MoMA device, the same MoMA device which we place the device which first inflate the compliant balloon in the external carotid artery and then inflate the compliant balloon in the common carotid artery so that we reverse the flow. And this time we are not worried about the toleration of the procedure because we have already opened the contralateral carotid artery. Next, please. Now we have got the MoMA device in place, and we can see there is a flow reversal which is well established. And what we also see here is that even the external carotid fills retrogradely. So this signifies that there could be there is some connection between the external carotid and internal carotid in this patient. So MoMA device, as we normally think, has zero risk of embolization. That's not true. There could be some sort of a collateralization between the internal and the external carotid artery, as we see in this patient. Next, please. And then we repeat the procedure, a similar procedure. We pass in a 014 guide wire across the lesion. This is a balloon dilatation with a 3 millimeter balloon. Next, please. And after that, we see that the artery is flowing well. Next. We place again a Cristello ideal stent. This is the same way. The closed cell design comes over the carotid bifurcation and the bulb and just at the proximal part of the internal carotid artery. Next. We place the stent and pull out the sheath. Next. After stenting, this is the result. Now we take out the MoMA device. Next, please. And this is the final completion angiogram on the left internal carotid artery. Next, please. This is the cerebral angiogram. So again, see, there is no distal embolization. This patient was fine. and then we took this patient for a coronary angioplasty. Next, please. Next, we have already diagonal stenosis and OM bifurcation stenosis. Next. So it's simple. We just put this is a 2.5 into 18 millimeter stent from Medtronic drug-eluting stent. Next. So the position looks okay. Next. And we've stented this, but there was a plaque shift or maybe a dissection at the distal edge of the stent, so we had to use another stent. Next, please. So this is the other stent going inside the first one. Next. This is the final result. Next. Then we went to the LED. This is a bifurcation balloon to LED diagonal. Next, please. We had 2 wires, one into the LED diagonal. This is the kissing balloon. Next. Then this is a long stent this is a Medtronic Resolute stent, 38 millimeter into 3 millimeter, placed in the LED, and there is another wire into the diagonal. Next, please. And this is then we took out that wire, and next, please. So this is the result which we got after putting in the stent into the LED. Next, please. So this is the case which we had done. I just wanted to show you how in an acute setting also we can use MoMA device. It comes to our rescue, especially in thrombotic lesions. We can use it in a bilateral internal carotid artery stenosis, and these patients did very well, and also we did a LED diagonal and OM bifurcation stenting.
Okay. This was a very very impressive case now. And can we address a few issues before we move to your next?
What are you doing, Anarind, here? You're doing the pudendal artery, is that right?
Okay, now, yes, now we have a patient. I'll just show you the angiogram. Now this patient has come from Afghanistan and he's a diabetic and has erectile dysfunction. His peak systolic penile velocity after pepaverine injection is only 18 centimeter per second, and he has a severe disease in the anterior trunk of the right internal pudendal artery. Now we did normally we follow all our patients.
Are there 2 pudendal arteries?
Now the thing is, normally when we do, we have been doing this since last 1 year. Whenever we do internal pudendal artery stenting for a male erectile dysfunction, essentially there has to be 2 things. These patients have to be excluded of any psychological cause or a medical cause. Secondly, there is a psychological and neurological assessment. Then these patients go for a penile Doppler. We have Dr. Kapoor with us, who is an expert, and he does penile Dopplers, I think, for all over Delhi. And you give an intracavernosal injection of pepaverine, about 60 milligram, and then wait for a tumescent response, and you also wait for then see what is the incremental increase in the peak velocity of the penile blood flow. Now, if it is less than 25 centimeter per second, this clearly signifies that there is a severe degree of inflow obstruction. Now, these patients also have to be complex ED patients. That means these patients have to fail Viagra therapy. So they have failed Viagra therapy, and then if you have these conditions, you suspect an internal pudendal artery or stenosis or a stenosis in the anterior trunk of the internal iliac arteries. There is an inflow obstruction. So these patients then qualify for an angiogram, and once, if on an angiogram we find that the internal pudendal artery has a stenosis or there is an inflow stenosis into the anterior trunk of internal iliac artery, then we go ahead and treat these patients, and most of these patients then with Viagra therapy start responding, and but the rate is quite variable. There have been a Zen trial which has been just completed. The benefits are quite variable and subjective. We still need to know what needs to be done. The CT angiogram is a good technique, but CT angiogram many a times will not give us the exact anatomy. And many a times we do CT angiogram, but to know what is the degree of tortuosity, what hardware to choose, especially if you are considering less use of the contrast, But in our practice, we normally do an angiogram and we also do a coronary angiogram. Like this patient had an angioplasty done in Afghanistan 2 years back. His stress test is negative. We have done a coronary angiogram also, which shows a disease in the LAD beyond the stent and also a disease in the mid RCA. So if you have any questions, it's okay. Otherwise, we are going to proceed and show you what the angiograms and what we have done.
How did these patients get referred to you? I mean, of course, it looks like that you've become an expert in doing it, but then who refers you? Is the urologist who refer you, or they come to you through their own means?
It's like both. You need to have friends with endocrinologist, urologist, and good like Dr. Kapoor, who does the penile Doppler for the entire city. So I know exactly if there is a patient, and then we can talk to the doctors and tell them that this is one of the ways we can treat them. And many patients do come to us, and now slowly the patient referral is they've started talking to each other and started coming.
What's the usual size of this pudendal artery? Just for the sake of interest, because I've never bothered to look at that area. But anyway, what's the usual size and how do you treat?
I would say the usual size would be around 2 to 3 millimeter, but it's variable. That's number one. The number two, pudendal artery, it comes off in a variety of variations from the anterior trunk of the internal iliac artery. So it's not always one path, and it's sometimes very, very tortuous. So you need to take many, many angulations to actually get into that artery, and then pass in devices and wires into that, hardwares into the internal pudendal artery. We always look at both the arteries. In fact, the next step is to do an angiogram of the bifurcation, common iliacs and internal iliac artery. The block could be anywhere, and then go selectively into the internal iliac artery. The internal iliac artery normally divides into two major trunks. One is the anterior trunk and one is the posterior trunk, and the internal pudendal artery is one of the branches of the anterior trunk. So the stenosis could be on any part from the anterior trunk down to the distal part of internal pudendal artery.
And one is not enough for you, is that right? So you have to have bilateral?
Normally, we check both. We treat one at a time. Normally, if the patient is symptomatic, you have a problem on both sides. But usually both sides, unless the other side is very small, and or a diffusely diseased vessel, like in this case. And also, we treat one vessel at a time. And initially, we are not, because it's not a very established procedure, we started with balloons and then only a bailout stent. Now we have gone from balloons to drug-eluting balloons, and sometimes elective stenting. I mean, the whole concept actually started about 15 to 18 years ago, but it's becoming, more catching a lot of interest now, especially in patients who have failed Viagra therapy and are quite symptomatic with this.
Any specific angulations in which we are working where we can best demonstrate the artery?
I would just take you through some. You have to take many, and I'll just show you the angiogram. Can I have the first one, right from coronary? Okay, so this is the angiogram of this patient. This is the coronary angiogram. Next, he had an LAD stent. Next, and he has a disease in the OM, and also a disease next beyond the stent in the LAD. Next, please. And he's got a mid right coronary artery stenosis, which is about 70%. So whenever we do coronaries these days with patients who have impotence, we check the internal pudendal artery, and patients who come with erectile dysfunction, we always check the coronaries, because there is a very, very high degree of correlation between the two if you have established erectile dysfunction. Otherwise, if you have erectile dysfunction, the literature says you can actually predate or predict coronary artery disease at least 5 years ahead of an acute coronary event. Next, please. We went initially from the right side, like we do an angiogram from the right side, so we can see the common iliacs are okay, the internal iliac proximal and distal part are okay. Next, please. Then we go selectively into the anterior branch of the internal iliac artery. Next, please. We normally use a Terumo diagnostic catheter, sometimes a Siemens catheter, and you take a Terumo wire. Now we rotate, normally for the left side we take angulations which are LAO caudal and RAO caudal, and sometimes areocranial depending on the tortuosity of the internal iliac artery. So here we have engaged the catheter into the internal branch selectively into the anterior branch of the internal iliac artery, and we can see many branches coming off from there. Next please. And then we go to the RA view. We can actually profile this long vessel which comes sort of crosses on the lower border is the internal pudendal artery, and there is a diffuse 70-80% stenosis, but 60-70% I would say, but it is not tight enough, and I don't want to actually dilate this because I think this is not the major cause of blood supply which is less. Next please. One more thing is when we are working up these patients, you may have a pudendal artery block, and these patients could be a complex ED and failing Viagra therapy, but the more common vascular cause is a venous leak. You have to exclude a venous leak, and then if you by exclusion you only suspect that there is an inflow arterial problem, then we go ahead and do this. Otherwise, you are not justified to do this because the most common vascular cause of erectile dysfunction is the venous leak. You see that there is a tight stenosis in the proximal part of the anterior trunk, and then there is a pudendal artery down which is diffusely and narrowly stenosed but not tightly stenosed. Next please. So this is a tight stenosis in the anterior trunk of the internal iliac artery and the pudendal artery, which seems to be okay. This is another view, an areocaudal angulation which shows the pudendal artery in profile, and it doesn't seem to be critically narrowed, it's just a diffuse plugging. We decided that we'll go ahead and treat the stenosis in the anterior trunk of the internal iliac artery, so which then branches out into the pudendal artery, and probably this would increase the pressure head and may make this patient responsive to phosphodiesterase inhibitor. So isko side mein laga do. So we are going to treat this stenosis. We have taken a contralateral approach. We have got a left femoral access, and we have passed in a 6 French RCA guiding catheter into the common iliac artery on the right side. Next. Okay, now we'll go live. Okay. So now we have taken a 4 French thermo catheter and a thermo wire. There is a king. We want to cross this and selectively intubate that artery.
Dr. Khanna, there is a question from the audience. Is there any role for fractional flow reserve testing in this size of arteries to assess the significance of the lesion? Have you come across any literature on this?
No, there has been no paper on that. No, nothing. No paper on that. But, doing physiological testing with this, the pipervarine, intracavernosal injection of pipervarine, and many a times it is even done on the table. And if you find no other lesion, then I think this lesion is significant and we should do it. Okay, can I have the stent now? So we have passed our wire into the anterior trunk of internal iliac. Internal pudendal artery is a branch of this, and now we are going to take 3.5 into 30 millimeter Endeavour Resolute stent and place it here. And we believe this should improve the functions. And Dr. Kapoor is going to do a penile Doppler after that, maybe after a few days, and then see, because right now the patient is anticoagulated, and then see whether the patient, the penile flow has increased or not increased. Okay, go up. Go up. 2468. 9, 10, 10, 11, 12, 13. Save. Deflate.
Yeah.
Save that. Okay. So we have put a 3.5 into 30 millimeter Endeavour Resolute stent. Can I have a DSA on this? Ready? So looks okay. So So this is the DSA, which looks better. You can see now the potential is filling up well.